Okay. First of all, I think the PowerPoints have to be very simple. Okay. I mean, today you would have noticed some of the PowerPoints which actually had similar kind of features. Okay. They were like Dipti's. You saw Dipti's PowerPoint? Okay. They were actually to the point, very simple. Okay. No Zazie background. Okay. Just had around maybe 4 or 5 lines to the maximum. Okay. And whatever was there in this were in the same fonts. Okay. It can be nothing more irritating than using different fonts. Whether you're using Arial or using any kind of special, try to use a similar kind of font on the whole of the paper, okay, on the page. Do not try to actually copy and paste in a whole lecture on it. Okay, one of the slides, which actually had something like, there were a few slides like that, where there were actually 15, 20 lines. Okay. Now what happens with those 15, 20 lines? Now I'm trying to speak to you, and you're trying to read. Okay. Now what happens is that is not there. So what we do is we need to look at the key points. Okay. Right. Then suddenly what happens? You got, on the side like that, and next thing comes out is a thing, but instead of a graph of this is actually, there is a cartoon. Right. Now you would have seen that while I was actually trying to talk to you, how many people are noticing I was taking out my tie? That's what it was. Okay. You got distracted. Immediately when I put my hand to the tie, okay, everybody started looking, what the hell is he doing with the tie? Isn't it? Okay, that is a distraction. So if you have got a cartoon on one side and you're actually giving a message on the right side, what will happen is you will actually forget the message, you would be actually interested in the cartoon. Okay, very wrong thing. You want to put a cartoon, let the people actually see that, and then move on to the next slide. Don't have it in the same slide. Okay. So these are very, very simple rules. If you look at the best presentations will never have a lot of animation either. Okay. You see some people, they will actually have one sentence coming from here, one from there, from below, from left and right, so rotating, and that is again very, very irritating. Okay. So if you actually want to stress something, so you got say 4 sentences. Okay. All you do is, you can actually put in a sort of a cover over each of them, okay, and they can disappear. But the best thing is, either you can have that, they get highlighted, so color changes. So you have black, and then the rest of them are gray. As you go on, the gray changes to black. So you can actually do that in the PowerPoint. You can change the color of these things. So that's the way of highlighting. But don't try to do that. Suddenly go zoom out, zoom in. All those things are not actually very useful in PowerPoint. Other than that, there are actually no big rules about actually having PowerPoint. PowerPoint should be they are actually considered, some people consider them as a distraction actually, rather than, because it has become such a, nobody actually uses flow charts or flip charts and things like that. Everybody wants, and trying to put all the information on one slide, that is the worst thing. You actually read an article. Okay, you want to put a paragraph from the article. First thing you do, take a highlighter and look for the keywords you want to convey. And that is the only keyword should be there on your PowerPoint. Other than keywords, you do not need more than that. So PowerPoint is very, very simple. Okay, now I'll show you how we formatted. Now you look at the font and things. You can't see the arrows. Okay. Now this was, I'm just going to show how we actually change this into a simpler PowerPoint. Okay. This is your. So you see that I've changed the fonts. Okay, those ones, they look more pleasant. Okay. And when it came to the thing, there was very important message in that, on the right side there was a graph or a pie chart. But what was more important was this, which was actually not been highlighted at all. Okay, it's showing that there are so many, brain injuries, 1.5 million brain injuries. Almost 50,000 people die every year. And 80,000, more than one number die, 80,000 impaired and disabled. And which was saying that, look, it is a burden on the state, okay, where state is not looking like India. Suppose anybody has a patient who is disabled in the family, whole family is disturbed. Okay, you need someone to care for them all through the day. Okay, you need to actually look at their personal needs. Okay, you need to modify your toilets and seats and whatnot. You can look how much burden it is. Now that has a very strong message. And that wasn't actually being highlighted in the previous slide. So you need to actually look at what needs to be highlighted. What you want to convey to the audience. Like, also important is what the audience actually is looking for. Like, you need to actually look at some presentation. Most of the presentation today was fantastic. Okay. There were some presentations where Surya, I would like to speak about. I'm very frank about things. Okay, you were actually reading everything. Okay, after some time it got boring. Okay, you were not interacting with the audience at all. Right, you need to interact with the audience when you're giving a talk. You need to, okay, fine, you can stand behind. Okay, but you need to interact with the audience. You need to look, what is the reaction? I want to tell you time out. You were not even, I couldn't even tell you that you were exceeding your 20 minutes watch is different from my 20 minutes. Okay, so you need to interact with the audience. You need to know what they are. So presentation, yes, good presentation is important, but if you cannot interact with the audience, then there's no point. Your very good lecture will become very boring. Okay. And you have to, because you need to know your slides, okay, what you're presenting, so you need to really have that and be able to talk rather than actually trying to read from your audience. Don't try to do that. Even if it means that you have those notes, okay, just for your prompt, don't try to actually just read the slides. It's a good presentation, but also how you present yourself to the audience is equally important. Okay, I think that's it. If any question on presentation, just go ahead.
Because appropriate font size to what?
Yes, font size. As I say, if you're only going to use 4 lines, okay, make sure the size is at least you can have anywhere from 24 to 32, depending on how many lines you want. But also make sure that you got equal spacing between them. Now you could write 4 sentences which finish here. Okay, they don't look good. Okay, so you actually have equal spacing between them as well. So spacing also important. But what kind of fonts you like doesn't matter. Okay. Again, don't use capital too much. Okay, it's very difficult. If you want people to read, it needs to be like either cursory writing we have, okay, so there are, or sentences, every sentence, but don't use capitals too much. Again, capitals are difficult to read. It takes more time to, if I give you a text with page, with all written in capital, it will take more time to read than normal text. So don't actually use capitals.
Is there any recommended color combination?
Yes, the best combination is black and white. Okay, worst combination is red or yellow, which actually, after sometimes your eyes will start hurting. Okay, now we use those kind of things. Okay, this is very, very pleasant to actually look at with right background. It doesn't hurt you. You can keep looking at 10 minutes, nothing will happen. So black and white is the best combination. You can always highlight few things with underlining, or you can change the color for keywords, but don't try to use different. Keep it simple. That is the thing. I mean, like we keep talking, his principle applies here as well. You keep it simple, it will always be more effective than any complicated presentation. Sorry? Yeah. Again, use a single page. Any graph, okay, you can use, but you can also bring in, suppose you have a message which you give that 36% or what there. So just looking at the graph itself, it may not be conveyed, even though you're trying to say look, I've got this bar chart which shows that 36% of patients actually aspirate during anesthesia. But you can actually bring out a message again. So when I black this thing with white, something like this, actually you can bring it in. So you can use at that time animation for actually bringing that up to get the message. Always nice to get a message. Highlighting that, so if you have got a pie chart, okay, you can actually say, this is what I want to show you this. What is the most important message within the chart? I'm trying to show you, talking about aspiration, then you need to actually highlight about aspiration happening. There's no point saying that 1% didn't aspirate, 2% did this, 2% that. What you want to show is highlight that 36% of the patient were aspirating after anesthesia.
Just I want to add something. The post-lunch session is sitting there, and it's quite unfortunate to see, but I mean, it's a basic thing that we do.
Yeah.
What I suggest to speakers who are doing post-lunch session is to do something more interactive.
Yeah.
Even if you have to pause your lecture, fine, and do some exercises or do some, make sure the audience is somewhere involved. Or it's okay to pause and do something. Sort of make it ways of doing some exercise, waking up exercises and things.
One of my colleagues actually on a difficult day, his lecture is always after my lecture. It's a kind of a constant format. Shusha has been on this thing. So mine is management unanticipated and his is anticipated. So once my lecture is over, first thing he does is says, okay guys, all get up. He will say, all raise your hands, do your this thing, do that. And he makes them actually do that before the lecture starts. I think that is asking the body to wake up. So doing simple things actually does that. Post-lunch sessions can be made interesting. So I was expecting a lot, so yeah, but never mind. Next time you'll have a better presentation. Anything?
Did you talk about practicing
Yeah, exactly. I mean, I actually email, message each and every faculty that 20 minutes. I know sometimes the topics are huge and it's difficult, but then again, it's again up to you how you condense that part. Again, it's about message. See, all of our anesthetists, we have some basic knowledge about things. Okay, now if you start telling me how to do a rapid sequence, what drugs you're going to do, I'm going to get bored. Okay, I might be interested in just knowing how will I apply inline manual tracking. I'm not interested whether you gave me propofol or you gave thiopentone or you gave, that is not my interest. That I know what I do every day. So it's immaterial, like having that information. Always know what information the public has got. That information is not necessarily you're wasting time. You're just making these people go to sleep. If they want to listen, they will not wake up. Naveen.
This is again a comment. On an unfortunate day, sometimes your presentations won't work for whatever technical reasons, and if you're in one talk, be prepared for those rainy days. And I would say that it's happened to me once. Like you go for a major national program of some kind, and then the audience are like twice your age, and you turn up and things don't work. And every second feels like a minute in the first few seconds, and then it becomes like years. And there's no way you postpone it, and you should know your talk. At least reasonably. Even if there's no slides, you must be able to get going, People will try to support you through, but you need to know what's the three main points of your talk at any time. So you may skip a lot of things. You might not be able to talk much about epidemiology and things, but 3 points, you must be able to talk about it for at least 10, 15 minutes.
I mean, I purposely didn't make a slide because initially I thought I will actually take some examples of bad presentations and then good presentations. Well, yes, it is one of the ways of doing it, but impromptu thing is very, very important, knowing your subject. You cannot interact with your audiences unless you know the subject. And that's why the subject somebody should not be given a subject which they have no idea about.
Small tricks for what you mentioned.
Yeah.
Just give a one-page printout of all your slides.
Yeah,
Right.
absolutely. Yeah.
I do that very often.
Yeah. A lot of people do that.
Just
Yeah.
one page printout.
Yeah.
So you learn a sequence.
Yeah.
It is your slide logo.
There are more things to actually PowerPoints, again, when you're presenting, which a lot of people don't know. I know, I think Dr. Vivek was looking for something else. Okay. Now you see that presentation, but look at what I have got here. Okay. So this tells me what my next slide is. I can actually have my notes. Okay, it's difficult to actually have small notes, but you can actually have at least few key points which you actually didn't have it here. You can actually have it in the notes. But most important thing, a lot of times you forget what your next slide is going to be. So it shows your next slide. One thing. Second thing, is got a timer. Okay, timing is very important. If the people actually organizers have told you, please take 20 minutes, finish at 19.9, 19.5. Do not try to exceed. Again, very irritating not only for the audiences who are getting bored, but also for the organizers because it's overrunning. So timing is important. Okay, this is called a presenter mode. Every PowerPoint should have a presenter mode, and it will take to you, but that's what it will show. It will show this screen, but rest of them it will tell you which. Yeah. This is Mac. Okay. But it should be there in everything. Actually, first one I saw was in a Windows one. The PowerPoint which actually had it's called go for the slideshow and options, which is called presenters mode. Yeah. PowerPoint is a very powerful tool. Actually, PowerPoint is called for a reason. Okay, all these templates, all these have been done only on the PowerPoint.
But you need to have a special arrangement with the AV guys to use the power presenters.
No. No? Not at all.
When
Yeah, yes. No.
When new computers know, but with the older version, you need to.
Okay. But here I have not been telling them anything. I actually choose what presenter mode is available. Yeah.
Have a backup. Have at least one or two USB sticks. Have been brought up once.
I did that last year. I've done once when I thought I want to take my laptop, I take the stick and the stick didn't open. Happened in regional anesthesia. And that was the first time I said, I made a mistake, I will never make a mistake.
2 sticks or 3?
No, it doesn't matter, 2 sticks.
On the cloud.
No stick would have worked because I work on a Mac and they were all these things and I think the virus got into the stick. Okay, it corrupted everything and a lot of things. Luckily one computer opened that. Even Hitters was a new computer. It did open the presentation.
Have it on the cloud, somewhere, either Dropbox or something, because you've got
Email yourself.
internet access.
Email yourself is another good idea.
Somewhere.
Next part of the session is about talking. If anybody is interested in working abroad, want to know, we got people here from abroad. Okay, we got from Australia. We got Nevin. We got Guru. We got people from UK. We got Senthil. We got Tushar. We got people from Dubai. Okay, we got Dr. Aziz Dazi. We got Piyush. So if you really people want to speak to them, okay, you can stay back and you can actually ask them questions. But I think, Senthil, do you want to tell them about MPI scheme because that's what you're interested in? Yeah, can you share? चाय पर चलते हैं I know चाय है क्या चाय नहीं
अभी तो ब्रांड पर चले
हाँ
This MPI is called Medical Training Initiative, whatever. Basically, somebody want to mic.
you can use this one here.
So in the past, when we all went to UK, most of us, we applied to the college with our qualifications, and then the college gave a sponsorship through a scheme called Overseas Doctors Training Scheme. So you don't have to take any PLAB exam. The college will give a sponsorship. So you go there, do a clinical attachment, and then you'll have find our own job. That's how we all went. And that was there for quite a long time. But I think around 2006 or 7, they took away this Overseas Doctors Training Scheme. And they started imposing a lot of restrictions for the foreign doctors to come in. So the number of people who were going into UK came down dramatically. So there was a sort of big gap in pretty much all the hospitals. At one level, I'll tell you what exactly that level is. So a lot of hospitals, what they've started doing is, basically, to put it straightforward, honestly, they want people, anesthetists to work at the registrar level. Yeah, it's called as the middle grade level or specialty doctors, or staff grades or whatever. So, to put it in simple terms, they want anesthetists, experienced anesthetists, to come and do mostly on calls. To do the resident on calls, fill up the gaps in the rota, because the number of trainees are pretty less going down, and they're taking very less trainees, as the years goes by. So quite a few hospitals in south of England, around London, they came over to sort of Chennai and other places, conducted sort of a small sort of informal interview, and then took candidates, and they're all sort of they know that they're going to work at one particular level, and they know that it's a non-progressional, which means that they cannot progress to a next level, which is a consultant level, because these posts are non-training posts. So basically, it's the hospitals are looking for someone to come and do a job for them. Yeah, and people who are interested in going to UK just for a different kind of experience, just to see how things are, just as a taster, and just to go around UK. So they all went there. Many people stayed over, still are continuing in that particular grade, because once mostly what will happen is, once you get into the grade, majority of them they become a bit more comfortable, and then get stuck in that particular grade. And I've known candidates who have come through those scheme, have worked hard, taken their exams, and they got back into rotation. But that is not guaranteed, really. That's a pretty rare situation, unless otherwise someone has a motivation. So the hospital I work in, so basically we are running out of people to cover rotas. Yeah. So they are looking into recruiting people, anesthetists, who should have at least 3 to 4 years of anesthesia experience. The name of the scheme is Medical Training Initiative, but there is no it's a non-training post here. The way it works is, they either can do an interview over the phone, or they might come here, do a sort of interview somewhere, and then give a job offer. With the job offer, you'll have to apply for your visa and everything. Basically, to get a visa in the Home Office in the UK, you need to have a job offer from the hospital. Yeah. So that is what I think Dr. Manisha's Mehta's hospital also looking into recruiting people like through this route. So it's in the early stages though, but I did put in a message that basically we wanted to know what people think and what their interests are and kind of stuff. So that is where we are. So simply, this is a non-training registrar level, an anesthetist post, mainly covering on calls and filling up gaps in the rota. But having said that, there are a lot of teaching program which goes on within the department and within the region.
You can still attend those teaching programs.
Yeah, the departments will allow you to attend all those programs. Like any other doctor, they will have a study fund. For example, I think it's about £2,000 for 3 years or so.
Yeah.
So if you want to attend courses, if you want to attend workshops, if you want to go on an echocardiography course, they will sponsor you. They will pay all your expenses for that. There is a limited budget, but if someone wants to utilize that in a very wise way, saying, because if you're staying for 2 years, it's better to utilize those funds and do some courses which might be useful for you in the future when you come back and practice. So ideally, I would say this is more suitable for those fresh candidates, who have not settled in a good position yet. Those who have settled down in a private practice with good practice and are happy, I don't think it's for them. Those who have got good jobs in corporate hospitals, I don't think they should leave their job and come here. But those who are pretty fresh, are post-MD, looking into some kind of overseas experience for some time, you can work in ICUs, you can work in maternity, and any exposure is definitely much better, in the sense you get to learn so many things. So those who are interested sort of in that kind of experience for a limited period of time. They say it's initially for a period of 2 years or so, but then it's we can always extend and kind of stuff. But again, we can't give that as a guarantee.
Yeah, it's basically again your supply and demand. Now, obviously, they can't directly go back to the overseas doctor training scheme, so they have used this name to actually get people in. You have to be lucky where you are going. Obviously, the hospital where Senthil works is a very nice hospital, very pleasant to work. And obviously, it's also important that people who are, suppose you're going to go through Senthil, okay, apply there. Obviously, you'll have someone who knows you. A lot of people, actually, I get a lot of mails asking, there is this MTI scheme. I have one thing you need to do. You have to remember that you need to have a good IELTS score. So you could actually have a job in hand, but if you haven't got a score of 8.5, you will not get a job. So if you are actually thinking of actually moving to UK, first thing you need to do is actually get an 8.5 score on IELTS.
8.5 or 7.5?
It's 7.5, sorry.
Yeah.
7.5. Is it? It's changed, okay.
Right, okay.
Yeah.
So yeah,
But it's not 8.5 though, it's... Yeah.
Okay.
I think it's 8.5 now. It's not 7.5 now, it's 8.5. No. Because I know recently some people who have given it, and they have got 8.5 something in some, and one of them they got 6. And that's it. Yeah. They lost the whole score because it's constant. Yeah, exactly. You have to actually pass each of them with a high score. So IELTS is whatever is there, you can actually find out from the net what score you want, they need, and you can actually go for that. But have the IELTS. No point actually taking up a job if you don't have a IELTS. It is not a difficult exam, but some people do still find it difficult. And I think they are actually a little bit strict about what kind of scores they give you.
Okay, so Dr. Pallavi.
Yeah. No, he says that the IELTS is valid for 2 years. Yeah. Okay. But once you are actually in a job, it doesn't matter because you get a job. It's valid for 2 years. Yeah, but if you actually job, because a lot of these jobs will actually tell you, can you join in next month? Can you join in 2 months? Okay, these are jobs. These are because these are filling up gaps, and suddenly gaps come up. So you got, say, 3 female registrars and 3 all get pregnant at the same time. And 3 go on a maternity leave. You got a gap of 3 people. I mean, it is changing statistics in anesthesia and medicine. Actually, there are a lot more females in medicine now than there were around 10 years back. So there are going to be gaps. So they're filling up gaps. There are instances where people have actually moved from these kind of jobs to training jobs. They're not easy. Okay, but again, it's again supply and demand. Okay, may not be in the Cambridge area, Oxford area. Okay, it might be somewhere very, not that posh. So, but you can still move on to a training job. People who asked me, if there were, there are a few young ones. I said, fine. You can afford to go for 2 years, but if somebody's got a family, 2 years and then coming back, it can be difficult getting back into a good job. So don't try to.
Definitely not for those who have settled and quite happy with their practice.
Sorry? This is a very important thing, okay? They will pay you well, but that is only what you actually look at. But what you're going to get into your pocket, 40% is going to go into taxes. That is on source, okay? 2% is going into national insurance. Okay, 42%. There'll be another few more taxes which you will be actually paying. You will, if you're driving, road tax, this tax, that tax, okay? You will be paying for your stay. They won't give you free. Okay, you'll have to look for your accommodation. There are hospital accommodations available, okay, but they are no cheaper than if you take a flat outside, okay? It's not very cheap. You pay for your water, you pay for your electricity. Okay, so by the time you actually are left with something, it might be just probably around 20-25% of your salary will be in your hand. So bills and everything. So it is not that liquidity. It might look nice because you would be converting, oh, I'm getting 68,000 into 100, 6 lakhs 8,000. No, it's not. So don't actually get
Cost of living
swayed
is
by the
quite-
cost of living is high.
quite high.
Yeah.
You might think we're all quite rich. That's not the case, honestly.
Yeah.
The one person who is really rich is those sitting there, Guru.
Yeah. Australia is still, I think, more liquid. A lot of people actually are moving from UK to Australia for very different reasons. But or you have to go at the very back there, the richest, they're at the back.
See, honestly, this can be taken in two ways. If you see, why should I go there and do a donkey's job? Basically, they're looking into filling up gaps. Why should I just go there and come back? So that is one kind of one way of looking at things. The other way is, right, let me go there just for a couple of years, just go around UK, go around places, and then see how the systems work in ICU, how the systems are in place in maternity. So, it's like a give and take policy. They want work from you, and you want to gain something from them. So it's up to an individual. People as clever as Dr. Pallavi can get their FRC like that and come back.
Yeah.
So it's a sort of give and take policy, honestly.
I actually get a bit of from people from Middle East because they're allowed to give their part 1 there, or they're actually, some of them are exempted from part 1. So if you are exempted from part 1, if you need to give part 2, you need to actually have worked in UK for 1 year. So for them again, it is like, okay, you get work experience and then you can actually give part 2. So you can get your fellowship. But if you're going straight from here, you have to give part 1 and part 2, and 2 years may not be enough for actually giving the exams. And if you have just a part 1 that has got no value at all, anyway, you have to have both parts to be able to write FRCA on the back of it, of your name. When did you reach here? Well, I've not seen it.
Just look different. Sorry, I just wanted to add a little bit. In addition to the youngsters going there, there is also a good opportunity for people who are doing subspecialty training in anesthetics to focus on MTI involving intensive care, MTI involving chronic pain, because one of our trainees, so we run a 1-year sort of fellowship, and she's got a MTI job in Scotland doing chronic pain. We've kind of established a link so that every year someone goes from here to train. But the one thing, the promise I asked her is to not to stay back for 2 years, because that will stop other people from going. Okay. I don't think 2 years is kind of a. I mean, this is purely. Yeah. But I mean, it is also useful for people who are in subspecialty training to go there just to gain some additional experience and come back.
I can assure you that when you go on the MTI scheme, at least you will spend, of the 2 years, you'll spend at least 1 year in the ITU, because that's where you have the most gaps in the
This is a specific.
No, they're saying that if they're looking at ITU, first thing they'll likely post you is in the ITU. Yeah.
This is a chronic pain job, actually.
No, that is very good, actually. If you're going for a very specialist kind of a job for a year, I think that's fantastic. Yeah.
First of all, lies, damn lies, and myths. Huh? There are some. I'll give you some facts.
Why did he move from UK to Australia? Ask him first.
Ask so many poems who are there, man. Anyway, I was in India, then moved to UK, and then I realized I had to go through a lengthy bit of training. Whereas in Australia, they do count your previous experience, and they may or may not exempt you from doing the whole training bit, right? So now I think UK and Australian training system is pretty much similar. 5 years of training, pretty boring. For especially somebody who's already experienced. There are good and bad parts in Australia. Now the good parts are the anesthesia and ICU have now completely separated. So if your core interest is ICU, you can go to ICU. There are some good and bad parts there. And if your core interest is anesthesia, then you can stay in anesthesia. it's a huge country, right? And there is workforce shortage issues in some places. Metropolitan system like cities, it's very hard to get into jobs. They are looking for jobs more in kind of semi-urban, rural healthcare system, which is far away from cities and things like that. There are different pathways to enter depending on your previous experience. Now, somebody who's already specialized and been working as a consultant, that's what is called as a specialist pathway. So basically what it involves is you send an application through the AMC with all your documents right from your medical graduation through your post-graduation, including the transcript certificate and the experience after the post-graduation. What they're trying to look at is how much is your experience compared to a consultant anesthetist in Australia. Now, when I went to Australia after being in UK as a senior house officer, they didn't even count my even single day in UK because my level of experience in terms of like, I was a consultant here, went down to SHO, and then applied for a consultant position. So I said, look, those 2 years you have spent there is useless. So it's ideal for somebody here who's been working as a consultant anesthetist, independent list, doing independently managing patients, having a good track record, maintaining good logbook, because that's very important when it comes to interview, which I'll tell you later. So at least 5 years of experience. If you've done MD and DNB, it's very good. DA is not recognized. DA, DNB is good again. All right. So I suggest those who are doing DA or just done DA, if you've done DNB, that's good because DA, DNB is 2 + 2, like 4 years equivalent. So that's good for them, that your training is for 4 years as compared to 3 years for MD. So what happens is when you put in the application, which is not cheap, I think it may come up to $3,000 or so, and then they will call you for an interview. So you have to go to Australia for an interview. In the interview, basically you will have different kinds of people. There will be senior anesthetist, and there will be a person from human resources, or even a common man can be sitting there. What they are trying to look at is what's your experience, what's your independence level, how you are doing as an independent anesthetist, how good are your skills, what you can bring to the country basically. And they will also would be interested to know like if you've got any specialty skills. Now, if you've stayed too much away from, if you've been doing only cardiac anesthesia for a few years, that's not a good thing. They want general anesthetist. That's what. Basically, you don't do cardiac anesthesia in rural places. So, depending on your CV, your previous experience, on all the referral letters and your logbook and everything, and the interview outcome, they will suggest whether you're equivalent to the Australian system or whether you need to do 1 or 2 years with or without exam, which often you'll be exempted from part 1 exam, so it will be just part 2 exam. So 1 or 2 years as a registrar, or they might tell you that you'll have to go through the whole training system. To get into the training system, it's almost impossible. Almost impossible because first you need to have a permanent residency to apply into any training scheme. So you may get a job, odd job out here and there, but you may never get it. I know a few anesthetists who have now become ED physicians because it's much easier to get into ED. They come there just to come into Australia. They come and join the ED where there is huge vacancy, and they keep trying for anesthesia. They can't get in, and then they just finish doing ED and they are ED consultant. Pay-wise, it depends where you are. In Australia, you can't practice in private for 10 years since being there. So they have got systems in place. They make sure that their own anesthetists are not deprived. So basically, you'll end up working in public health system, and rates are quite negotiable depending on which state you are, which country health system, depending on how desperate they are and all those things. So anywhere from 250 grand to 300 grand is what you can achieve, and we got 50% tax rate. So better be aware. And cost of living is much more than UK. So we are not rich. Naveen will talk about ICU.
Myth.
Yes, no, pointed my finger at the person.
Man in the white coat.
That's why I was looking back.
He is probably looking forward to buy a
So,
We ask him now, Nick, ask him to come and tell us. Devin can tell us about ITU.
yeah. So taking over from where Guru left us. So the colleges have separated. I think in the last 3 years they've become like independent bodies. So any anesthesia experience probably be counted for the total ICU training is for 5 years. So it's divided into now 3 core years in intensive care. They need 1 year at least mandatorily in general medicine and 1 year in anesthesia. So if you're trained as an anesthetist in India, they would usually give you 1 year of that exemption time in anesthetic time. So you don't have to find a rotation in an anesthesia department in Australia. That's all what it amounts to. The realistic possibility of any overseas specialist getting as a direct consultant job in Australia in intensive care is 0, I would say. Even if you're trained in US, UK, they'll say, okay, we will assess you. Inevitably, they'll say partially comparable. I've never heard of anyone, unless they've been invited by the college to be told it's comparable. So you could have done your training in US, you'll come back and they'll be asked either to do an exam or they'll have to do supervised training. And the exams, if you're not trained in the system, they're very, very hard to get through. It's designed for the people who have spent time. It's not that how knowledgeable you are or how clever you are. It's like how you can play the game, pretty much. So realistically, most people, like previously mentioned, it's the ideal kind of person who should be applying would be on the younger side, who's just postgrad and interested in intensive care. Whether you would get a training position, it's increasingly very hard. I would say very, very hard now. There's a silver lining now, given that there's shortage of, in some areas, I think a lot of private intensive care is coming up, and there may be slots, if not for full training. I think it's something similar to what you told about NTI. It's not in complete process yet, but in a year it may happen, where they would consider people for short-term training. But the catch is, again, it would not guarantee you a full-time equivalent CICM membership. So it's like what the edict does in India. You know, they come and conduct exams and they'll give you a certificate telling you are a European diploma in intensive care, but you have no practicing rights in Europe. So I think Australia is trying to catch up on the same system where you may get work experience, you may get some kind of acknowledgement of the fact that you probably worked and would benefit when you go back to your country of origin. The other thing is that the immigration and colleges, they don't work in parallel. So even if you go for your interviews and things are in place, the onus of responsibility of finding a job lies in yourself. So that's again tricky. Like most people find out only halfway in the process that they spend a lot of money, they've done their IELTS, and they find that they're employable and they don't get a job. And unless you have a job, you can't get a visa. So it can get quite frustrating. But for people who have already entered the country by some means, one of the opportunity is to go through the non-training pathway at least to start off and then go from there. I think overall the pay is around, as a registrar, you'll be anywhere, depending on number of years post-MBBS, anywhere between $80,000 to $100,000, and you probably live reasonably okay. Any other questions?
So basically very tough for guys to get in.
In a full-fledged training scheme, it's quite hard.
Yeah, I think they have very hard on it.
I want to do a fellowship. Is there an option available, like fellowship in India?
Yeah, I think, yeah.
That's very
Tushar will be the right person, to answer your query because, he's taken in charge of FRC. Right.
For the Australian post-diploma 3 years of experience, how can I apply?
ICU or anesthesia?
Yeah.
So do I see you?
So I think, to be honest, you'll have to start from scratch. You will have to do your IELTS. You write to College of Intensive Care, who would assess you and may give you an exemption for primary exam. But again, no promises.
They don't. Even I didn't get an exemption too.
No, he has done ICU.
No.
No, I have not done any fellowship.
diploma in anesthesia in 3 years.
Oh, okay. So you're not done a critical care. So you unlikely that you'll get any benefit. You'll have to start from scratch.
So, look, from my knowledge, getting into ICU as a registrar is not that difficult. There are lots of places, Royal Adelaide Hospital in Adelaide where I work, I still know, they do recruit people, especially from CMC Vellore. They've got good tie-ups there. St. John's Bangalore, they've got connection there. So it's easy to get into a registrar position. That's how I went to that country. I got into ICU registrar. And I thought I'll do intensive care, and then I realized intensive care, the college was causing problems, and I said bye and jumped. So it's easy to get into ICU or ED as a registrar. Once you are in there, if you're really interested in ICU, and if you don't mind, waiting for a few long years, so you can get into as a ICU as a registrar. They may or may not give as a registrar. Or ED is much easier. Get in there, get your visa stamped as a permanent residence, which may take up to 2 or 3 years. Of course, you'll have to go through AMC, part 1, part 2, and then get a job. The good part about Australia compared to UK is that you can start working after AMC part 1. But part 2 requirements are slightly different. You should do ICU, not ICU, medicine, surgery, and ED. But often the ED people, they can arrange all those things for the sake of exam. So I know a few people who have done DA who come there as ED registrar, and but then they got stuck with ED. But they finished ED and now ED consultant. They're happy with that. It all depends what's your priority. Or you can then, once you get into PR, then you can kind of play the game slightly more easily. You can then apply for ICU registrar, then do the ICU training. It's a long drawn process.
Right, guys, it's not all doom and gloom, okay, in the UK. It depends on how Modi gets on with the British government. It's all political. Things will change. Things can change.
And Australia as well is visiting us.
Yeah. That's why I'm here.
And if depends on how you want to go and work in the UK. Do you want to go to get experience, or do you want to go and get trained and settle down in training and then hopefully settle down in the future? If you want some experience, if you want to do a little fellowship, a non-training fellowship, 3 years of experience, I think it's quite easy at the moment. You just have to find the right job, get in touch. If they have space, they will beg you to come. They will, in Whiston, where I am, they're looking for fellows. They want people to come and do ICU.
What fellowship? Anesthesia. There is no one. ITC, they're basically very limited kind of one place where you actually need more workforces in ITU.
What fellowship?
Lot more.
Walton Center. Walton is always free, isn't it? I'll give you the name of the person. You get in touch and find out. Because nobody wants to do it.
Let me know. I can talk to them. All of us have worked there.
Right. If you are interested in training, then you have to come with an idea that you may have to come back. You may not get it. Okay? But if you do come there, I know one person who was a fellow who came for experience, post-MD, who came for experience. They liked him so much.